Good afternoon. At the outset, I would like to thank the organizers for having given me the opportunity to be before this elite audience. Today, I would be talking about 2D analysis and Doppler echocardiography in mitral stenosis. It will be a 15-minute talk. I'll be talking about 2D features of mitral stenosis, the Doppler evaluation of mitral stenosis, the associated feature, what's new, and how I usually go about it. Coming to the 2D features of rheumatic mitral stenosis. There is leaflet thickening, and characteristic of the leaflet thickening is it starts at the leaflet tips and moves on to the base. There is also reduced leaflet mobility, especially of the posterior mitral leaflet, and the anterior mitral leaflet takes the characteristic doming shape. This occurs because the tip of the leaflet is restricted while the body of the leaflet is free to move, giving it the characteristic hockey stick appearance at end diastole. You also have commissural fusion. This is best viewed in the transgastric basal short axis. Here you see a commissure, the anterolateral commissure which is fused and the posterolateral commissure which is free. It's quite difficult to look at this commissural fusion in a 2D. It's more easier to look at commissural fusion in a 3D. This is a 3D zoom which is cropped from the left ventricular side, and you can see that the anterolateral commissure is fused while the posterolateral commissure is free. And this commissural fusion gives it the characteristic fish mouth appearance in rheumatic mitral stenosis. You also have thickened and shortened chordae and also hypertrophied papillary muscles. Coming to the 2D echo features of calcific mitral stenosis. Now we will have to differentiate calcific mitral stenosis from rheumatic mitral stenosis. In calcific mitral stenosis, there is less commissural fusion and the smallest mitral valve area is at the base. This gives the mitral valve orifice a tubular shape, and the calcification extends from the annulus to the base as opposed to from the leaflet to the tip base in rheumatic mitral stenosis. Now this is a picture of calcific mitral stenosis. You can see a lot of calcium on the leaflet tips, giving it a characteristic 2D appearance. This is a 3D picture, it's a 3D zoom from the left atrial perspective. You're looking at a calcific mitral valve and the arrows are showing a heavily calcified mitral annulus, mitral annular calcification. Now coming to the Doppler evaluation of mitral stenosis. The first one is transmitral pressure gradient. Now you'll have to get a continuous wave Doppler across the mitral valve leaflet tips in one of the mid-esophageal views, and on tracing this continuous wave Doppler, you would get the max gradient and the mean gradient. We usually use the mean gradient to classify mitral stenosis. The peak gradient is not used to classify mitral stenosis as it is influenced by atrial compliance and left ventricular diastolic function. We can grade mitral stenosis based on the pressure gradient, and any gradient greater than 10 millimeters of mercury is severe mitral stenosis. Now there are certain fallacies in using pressure gradient for classification of mitral stenosis. There can be underestimation of mitral stenosis if there's a non-linear sampling beam, there's a type 1 diastolic dysfunction or a low cardiac output. And there's an overestimation of mitral stenosis during tachycardia, type 3 diastolic dysfunction, elevated cardiac output and mitral regurgitation. The second modality is mitral valve area by planimetry. This is the gold standard and reference method for mitral valve area calculation, and biplane imaging is preferred in 2D planimetry. The crux here is the plane should pass through the tip of the leaflets and not the base of the leaflets in rheumatic mitral stenosis to calculate accurately the mitral valve orifice. Now 2D planimetry measures anatomical mitral valve area, while functional mitral valve area is calculated by PISA, pressure half time and 3D planimetry. The advantages of using planimetry is it is less dependent on flow conditions, chamber compliance and associated valve lesions. The disadvantage is it is not accurate in severely distorted valves. Now planimetry also has its fallacies. You can underestimate MS if the gain is too high, if there is tachycardia or in a post-valvuloplasty situation. And you can overestimate MS if the gain is too low or if the scan plane is passing through the body of the leaflets. Grading of MS can also be done by planimetry, and any area less than 1 square centimeter is severe mitral stenosis. Mitral valve area can also be planimetried by 3D multiplanar reformatting, and this is more accurate than 2D mitral valve area planimetry. 2D planimetry overestimates mitral valve area compared to 3D, especially in patients with large left atriums. The third modality is pressure half time. It is the time in milliseconds for the atrioventricular pressure difference to decrease from maximum to 1/2 of the value, and the rate of pressure decline depends on the cross-section area of the mitral valve. The mitral valve area is got by the Hartley formula, which is 220 by pressure half time. Now, what is 220? It is a constant which is a product of the net compliance of the LA and LV times the square root of the transmitral pressure gradient. Now, you'll have to get a continuous wave Doppler tracing across the mitral valve, and you'll have to place one cursor at the peak gradient and the other cursor just before the start of the A wave. The slope between the cursors is the deceleration slope, and the machine calculates the mitral valve area from the pressure half time. The pressure half time can also be used for grading of mitral stenosis, and any pressure half time greater than 220 milliseconds is severe mitral stenosis. There can also be fallacies in using pressure half time to classify mitral stenosis. It can be underestimated in conditions where there is an increased pressure half time, like bradycardia and impaired LV relaxation. When there is a decreased pressure half time, there can be an overestimation of mitral stenosis. These conditions include severe AR, MR, AS, a type 3 diastolic dysfunction, high preload, tachycardia, poor LA compliance, and ASD. Pressure half time is unreliable in post-BMV situations, post-MV repair situations, calcific MS, atrial tachycardia, and restrictive cardiomyopathy. Now, the fourth modality of evaluating mitral valve area is continuity equation. It is based on the law of conservation of mass of hydrodynamics, which basically says the flow volume at the mitral valve is equal to the flow volume at the aortic valve or the pulmonic valve. It is derived from the formula mitral valve area is equal to the cross-sectional area of the LVOT into the VTI of the LVOT divided by the mitral valve VTI. So, to get the mitral valve area from the continuity equation, you need the diameter of the LVOT, the continuous wave Doppler tracing to look at the VTI, and the LVOT VTI. Substituting these values, you would get the mitral valve area. Now, the continuity equation is independent of transvalvular gradients, LV compliance, and changing hemodynamic conditions like exercise. But it should not be used in atrial fibrillation when there are shunts and if there is a more than mild MR or AR. The fifth modality of evaluation is proximal isovelocity surface area, based on the continuity principle, which states that the peak flow rate across any hemispherical shell proximal to the mitral valve orifice is equal to the peak flow rate across the mitral valve orifice. It is derived from the formula 2 pi r square into arising velocity into alpha 180 by Vmax across the mitral valve. Now, this alpha is the angle subtended by the mitral valve leaflets at diastole, and this is the correction factor which we have to include. Now, you have to get an end diastolic frame, and you'll have to get the arising velocity between 30 and 40. The PISA radius here measured is around 5 millimeters and the angle subtended is around 120. Substituting the formula, you would get the mitral valve area. When do we use PISA? When there are technical limitations to use 2D planimetry, when hemodynamic changes affect pressure half time, and continuity equation can't be used. The limitations of PISA is it is time consuming, you'll have to make several measurements. The model of PISA is based on hemispherical flow, while the rheumatic orifice is elliptical. And this hemispherical shape occurs only at arising velocity between 30 and 40 centimeter per second. This is not valid in atrial fibrillation, but the greatest advantage of PISA is it can be used in MS with MR. So, what are the associated features of mitral stenosis? You can have an LA dilatation, a spontaneous echo contrast which leads to thromboembolism, LA thrombus, and left atrial appendage thrombus. Because of the pulmonary hypertension and the back pressure effects, you can have right ventricular hypertension, right atrial and right ventricular dilatation, and the classical D-shaped septum at systole and diastole because of pressure overload along with a dilated RV. The most common valvular lesion associated with MS is tricuspid regurgitation, and whenever your tricuspid annulus is greater than 21 mm per meter square body surface area, it is recommended to address the tricuspid valve in the presence of a mitral stenosis. The other associated lesions can be an MS with MR and an MS with AS. Now, there's a lot of debate about left ventricular systolic dysfunction in mitral stenosis. The causes are basal infralateral valve scarring, acute attacks of pancreatitis, and impaired diastolic function. But what has recently been found out is the end-systolic elastance, which is the gold standard of intrinsic LV contractility, is normal in mitral stenosis. So this is a picture of the basal infralateral wall in the midisophageal long axis view. So coming to the pathophysiology of left ventricular systolic dysfunction, there is a scarred and foreshortened chordae which causes tethering and prevents the LV free wall from expanding at diastole. This decreases LV filling. At the same time, because of pulmonary artery hypertension, there is a predominant early diastolic RV filling. There is a paradoxical leftward motion of the intraventricular septum and diastole causing a decreased LV filling. The end result is there is a decreased global longitudinal strain, and this is due to a reduced preload. Now, this is the 2020 ACC/AHA guidelines for classification of mitral stenosis. It is based on the mitral valve area, the pressure half time, the pulmonary artery systolic pressure, and the symptoms. So, what's new in mitral stenosis evaluation? There is something called as low flow, low gradient mitral stenosis. In elderly, there is a decreased LV compliance which causes an increased LA volume, a decreased LA compliance, and an increased LA pressure. This results in dyspnea and effort intolerance. There is also a decreased LV compliance from left ventricular diastolic dysfunction causing an increased LV diastolic pressure. So you have an increased LA pressure, at the same time an increased LV diastolic pressure, and hence you have a reduced transmitral gradient. Now, what are the characteristics of low flow, low gradient mitral stenosis? Low flow, you have a stroke volume which is less than 35 mils per meter square, and this is due to decreased mitral valve area, decreased LV filling, and severe subvalvular disease. The low gradient is due to low flows and rapid equalization of LA and LV pressures, and these patients usually present with dyspnea. Now, can we diagnose low flow, low gradient mitral stenosis? Yes, by something called as the net atrioventricular compliance. It is basically 1270, which is a constant, into the planimetry mitral valve area divided by the mitral valve E-wave deceleration slope, and any net compliance less than 4 mils per millimeter of mercury is low flow, low gradient mitral stenosis. So you'll have to know the mitral valve area by planimetry and the E-wave deceleration slope, and you can calculate the net compliance to diagnose low flow, low gradient mitral stenosis. There's a lot of work done on LA strain in mitral stenosis. There is a decreased peak LA reservoir strain, and there's a decreased conduit strain, reflecting mitral stenosis affecting the LA and LV diastolic dysfunction. So how do I usually go about evaluating mitral stenosis? I would first do a 2D evaluation. Then I would do a mitral valve assessment by mean gradient, pressure half time, and planimetry. If there's a discrepancy in values and if the image quality is good, I would use mitral valve area by planimetry as the reference. And if there's discrepancy in values and if the image quality is poor, then I would go on to use continuity equation and PISA. I would leave you with enchanting images of interior Karnataka. Thank you.